So I've already started the recording. So did we even look at this week's material?
I did.
Okay. All right. Any questions before we get started?
What are we going to cover today?
I'm going to start with peripheral vascular disease, but we've actually had this one before when we talked about gas exchange. So this would actually be a review of that material.
Okay.
So I'm going to start there and then go to high blood pressure or hypertension, and then go to heart failure. And if time permitting, then we'll do prolapse, mitral valve prolapse.
Mrs. Hudson, I'm sorry, I have a question just off the subject of lecture.
Yeah.
Do anybody know what time our skills exam is for tomorrow? Is it for 7:30 as well, or a different time?
Which skills, babe?
We have a skills exam tomorrow.
Is that
I'm in the bridge. I guess it's different. Yes.
Okay. Have you emailed Ms. Pritchett?
No. I emailed a few of my classmates, but I hadn't received an email back. I just emailed Ms. Pritchett.
Email Ms. Pritchett, and then if you don't get an answer back, let me try and text her.
Just to be safe, I just show up at 7:30.
Okay. I know she's.
But thank you, ma'am.
I said I know she's at work pretty early.
Okay.
All right, so before we get into this week's material, I kind of wanted to backtrack to exam 3. So I don't know if you all care to share comments on your thoughts about the exam prior to, then I'm going to have just kind of a wrap up related to that, and then we're going to roll on to the next piece. Anyone care to comment? No comment?
What was the question? I'm sorry.
Just your thoughts about exam 3. I will say the J2's class average for all sections was about a 75.7, somewhere in there. So like barely at passing.
I thought the material was covered pretty well in the lecture and in the Zoom session. I mean, indirectly, you gave a lot of the points that was on the exam.
Okay.
I thought personally it was fair.
Okay.
I overthought it.
You overthought it, and sometimes that happens. So the key points I want you to take away from that is that exam's dead and gone, meaning it's done. And it doesn't mean you can't learn from it, but I don't want you all wrapped up on that exam that you don't prep for this exam. Does that make sense?
But still has it.
Are we okay? That's a little crazy. Secondly, that was more of a rote memory. So it's like, this is hyperkalemia, what are the causes? What condition, relates to it? How do you recognize it? How do you treat it? So I would just make some flashcards of all of those hyper and hypos, like when you get to that Thanksgiving break. That'll give you some time to kind of jot those things down before you take the comprehensive and HESI to get them solidified in your mind. As you move towards third, they're going to be expecting you to already know it. So this will be a good way for you to kind of get it, more refined in your mind. So that way you don't overthink it. That way you don't think it's so cumbersome. The other thing is, if you think electrolytes or fluid and electrolytes is so much information, then you kind of stop your brain from being able to absorb it in. Does that make sense? Because once you get to view it or you start reviewing, then you're like, oh my gosh, this is so much. But you have to do it in little pieces. You can't wait till the weekend and then start trying to put some fire underfoot. those are the types of things that you work on steadily, and you get more, you solidify the little pieces and then put them together. So remember, I talked about don't group, all low sodiums to SiADH. Don't loop all hypernatremias to this one. So you can have hyper and hyponatremia without either of those conditions, DI or SiADH. Does that make sense?
Mm-hmm.
Okay. So, just trying to, when you're looking at that cellular level, you do get a little bit, it's overwhelming. So that's why you have to study small pieces all the time, but you can't do those small pieces in chunks over the weekend. So you got to kind of look at it through the week for a little bit. Okay. So outside of that, then I'm going to go ahead and move on to the peripheral vascular, that one, and then we're going to go on if there aren't any other questions. Okay. Cool. So I believe you already have this PowerPoint somewhere in your course board. And we kind of covered this again prior to already in today's lecture or to today's material. Tomorrow, on Tuesday, we'll go back and look at the all of the lab values that's associated with coronary artery disease. So that way we can refresh our mind about the LDLs and the HDLs, and we can kind of all be on point. All right, so with that being said, I feel like I'm missing something here. With that being said, just going back to peripheral arterial disease or peripheral vascular disease also encompasses peripheral arterial disease. So, this looks at how much damage is being done to the arteries. But in order to understand that, then we have to look at the two conditions that usually happens to the vessels. And when we have peripheral vascular disease, we also have a decrease in blood flow. So that means that decrease in blood flow is also going to hamper the ability of blood to reach organs that are needing oxygen-rich blood. So it's not going to get to our target organs, okay? So two conditions, atherosclerosis, I usually start with that one first, and that's because that's the condition that usually happens first to help or to facilitate peripheral vascular and peripheral arterial disease. And that's basically an accumulation of cholesterol and calcium salts into that bind and collect into the lumen of the vessel. And it actually makes that vessel more narrow. So the blood flow going through there is going to be more turbulent blood flow, which allows then, if you have turbulent blood flow, what occurs?
Like you're talking about a high pressure of blood flow?
Right, as blood moves through the vessel and you have, plaque build up along those vessel walls, and it's not just in the heart, it's plaque throughout all vessels. So my question is, when that happens, what happens to the blood flow? Does it freely flow through? Is it turbulent? What happens?
Resistance because of the buildup.
So it becomes more turbulent, which sets the patient up for clots. So as that blood flow goes through, then it's going to start to damage those red blood cells, and then we're going to start having the inflammatory process kicks in, and we're going to now start having clumping or aggregation, which will later on lead to some type of clot formation, okay? So in order to get arterial sclerosis, you would normally have atherosclerosis. And arterial sclerosis is basically the hardening of the artery because it's lost its elasticity, it's kind of thickened, and we've now built up calcification along those walls. So therefore, that middle layer of the blood vessel, which is the tunica media, it doesn't dilate and contract like it used to. So it makes the vessel a lot more stiff. And in practice, if you have someone that does have high cholesterol, that individual, when you draw their blood work, it may actually be kind of a purpley color, and it'll have, you can see the lipids actually in the blood. Okay. So other diseases or risk factors are going to be your diabetes, someone that has high cholesterol in the blood, hypertension because of its vasoconstriction of the vessels. Smoking, more specifically the nicotine, actually causes vasoconstriction. And then higher elevations of hormones like estrogen will cause, we have that similar effects of coronary artery disease. So although this PowerPoint says it affects people in the 60s and 70s, there's people in their 40s, their 30s, even younger that have, high cholesterol, hypertension. It's becoming more prevalent than less common. It does affect more men than women. However, once women lose those protective measures from their hormone levels, more specifically their estrogen, and they go into menopause, then those women start to have a lot more cardiovascular problems like heart attacks and things like that. So kind of a recap, we do have, it's still considered lesions develop within the vessels. Both the intima and the media arteries, and that's the tunica of the blood vessels, what it's speaking of, are now becoming impacted by the high cholesterol levels or by the peripheral vascular disease. So plaque then, develops all throughout, and then the way it affects the individual is going to be different, but tissues distally will not be able to receive the oxygen-rich blood. So now you may have more colder extremities distally than you would than normal, and that would be in an artery. In a vein, if you have a clot in the vein, then it tends to have more inflammation and warmth to that respective extremity than it will if you have an arterial clot. With an arterial clot, you'll end up with, decrease or lack of pulses, intermittent claudication. You could have that, but the extremity would be cold. So you would have unilateral coldness of an extremity. Sometimes collateral circulation will develop to help with the blood flow, but that's not always enough to perfuse those extremities distal to that blocked area. So by the time you start seeing signs and symptoms, 60% or more of that vessel has already been occluded. So the intermittent claudication is basically as the patient's walking, they're experiencing pain in their calf. Or if they're at rest, then their legs have that burning and tingling sensation. So may report some numbness, they may report some decrease in sensation, peripheral pulses may be diminished or absent, skin pale, extremity dark red when dependent. So it's like as soon as they get up and they start moving around on it, the leg just turns, really red. The skin's really thin and it's kind of shiny, so there's a lack of hair on that skin. So it's almost like the skin's been kind of burned. Thickened toenails. A lot of people don't take care of their feet, but you can look at their feet and tell that there's an issue there. Skin areas of discoloration do exist, and then they can have another sign of peripheral vascular disease would be the sign of an ulcer secondary to what?
Peripheral vascular disease.
Right, but why do they get that? Why do they get the ulcers? What is their condition that they might have related to that?
Like venous stasis.
Could have venous stasis. What else?
Blood clots.
Not for the ulcer. Think of some of the risk factors. Diabetes.
Diabetes, okay.
Okay. So looking at venous insufficiency, basically the body isn't getting enough or doesn't have adequate venous return over a period of time. So there's lack of blood flow making it back to the right atria. So these are usually causes of a person, that may or causes for a person having venous insufficiency would be they have a deep vein thrombosis or varicose veins. So that's those tortuous veins from standing on your feet for a long period of time, or, cross legs, not using support hoses when you're working. So those are the types of things that prevent the blood flow from continuing back to the right atria. But you also have valve insufficiency is the reason why you can't get that blood to move forward. Sometimes it's idiopathic. They're not really sure of the reason, but certain conditions can also lend itself to venous insufficiency. So the lower leg becomes edematous. It gets worse when you're standing. There's pain that increases when you're standing. Thin, shiny skin. Could have a little bit of brown pigmentation of the lower leg and the foot, or it could have some cyanosis. Cyanosis means that's been going on a long time, so that means blood flow's not there, right? So things we can do, TED hose or compression socks. In hospital, they'll use the SCDs or the sequential compression devices. So you put I'm trying to think of the name, that you wrap around the leg, so that way you can hook it up to the device. So you put the compression hoses on. They may do a stress test to see if the patient, as they're walking, do they have more pain? Does that intermittent claudication become more frequent? They do a Doppler ultrasound to, test and see if the blood flow is still going through, if it's turbulent or not turbulent. So there's a lot of different things that they can look at to diagnose whether they have peripheral arterial or vascular disease. Angiography, they can go in and look at the pressures of the artery, or see if there's just blood flow in the veins, if there's occlusion, and then how much occlusion. So usually peripheral vascular disease is diagnosed with a history and physical exam, and the diagnostic test just looks at the extent of the damage. So which of the perfusion antecedents, on the analysis diagram are involved with peripheral vascular disease?
Heart failure.
So that would be an antecedent. What's antecedent when we're looking at lecture?
Like a characteristic, or what has to be, or what's a condition that's in place that could lead to this disease?
So this would be what should be normal, correct? For antecedents? Okay. So you need to have good vessels, you need to have good blood flow, the person should be up and moving around, no signs of diabetes or a non-smoker. So anything that's going to cause vasoconstriction, that's what you want your antecedents to be opposite of that. So, normal vessel size, no vasoconstriction, non-smoker, that would be what you would be looking at. Does that make sense?
Mm-hmm.
All right. So how is peripheral vascular disease attributes or attributes assessment difference from the optimal attributes listed in the analysis diagram? Have you looked at anyone looked at or took a look at your concept diagram, since we're talking about perfusion?
I haven't looked at the concept diagram. I just looked at the PowerPoints.
Okay. Anybody else?
I have it. I'm pulling it up now.
Okay.
Mrs. Hudson, can you show how you get to the diagram?
So before, I will once I stop sharing screen. So once we get through this one, then I'll show you how to get to the diagrams. Or do you want me to show you that now?
Oh, no, we can wait. Thank you.
Okay. Oops. That's my finger. Anyone find it yet? Or we're still looking. So go.
I'm sorry. I'm there. What was the question?
I was asking, did anyone find the concept diagram? So your concept map or perfusion for lecture. And there's a reason why I'm actually being specific. If you go to community, where you get on you all side of the house, when you go to community, then there's a tab that says concept diagrams. And so the concept diagram that's there, because there's one for clinical, don't click that one.
Okay, I'm at the one where it says concept diagram.
Right, so then it should be listed all of the concept maps for J2. So go down to 1533.
Mm-hmm.
And when you get there, then you should see the one for perfusion and what it would entail.
Okay.
And your question is just what are the characteristics of a patient with PVD versus a non?
Well, it's the second question. How is peripheral vascular disease attributes assessment different from your optimal attributes listed in the analysis? So we're looking at assessment attributes to optimal attributes.
So from the concept map, it talks about blood pressures within normal limits, capillary refill less than 2 seconds, pulses within normal limits. And so with a patient with peripheral vascular disease, their pulse may be like with arterial, they may not have a pulse or diminished.
So your assessment would be lack of pulses or diminished pulses, right? But
Right.
your optimal attributes. So you want them to have good blood flow. So they're looking at the difference between what you find on assessment and what your optimal attributes would be. So it's just basically tying it back to your concept map and just not saying, okay, these concept maps are here, no big deal. Because you can still have, what if it's not an extremity? What if it's your carotid artery? What problem would you see with your patient if it's the carotid artery?
Like they would probably not be responsive because of lack of blood flow
Where's the lack of blood flow happening?
to the head or to
To
the
the
heart.
head. So they could end up with a stroke. They can end up with a transient ischemic attack. So those are some things that can happen to a patient. If those clogged arteries was in the heart, and I know we're talking about, we focus a lot when we talk about PVD on the extremities and DVT and all of that. But the truth of the matter is you can still have all of these other problems related to it. So though it's not just the extremities, but besides, coronary artery disease, the patient can have a stroke, they can have a peripheral arterial disease, and peripheral arterial disease is under the umbrella of peripheral vascular disease. So although it's more commonly your legs are affected, we still have other areas that can also become ischemic or basically have a lack of oxygen, feeding those prospective sources. Does that make sense? So here's some therapies that we can use. They can either have aspirin, so that's, that would be one. What other medication?
Your anticoagulants.
So they can have other anticoagulants to help, decrease clotting.
Or any kind of cholesterol medication.
Right. I'm sorry, that was my hand that hit that. Cholesterol would minimize the cholesterol in the blood or in the blood vessels. However, this one talks about vasodilators. That's basically making the vessel bigger to allow more blood flow to go through. And that's kind of a temporary fix in my opinion. So the bigger things would be, how about healthier diet, eating habits, eat healthier. TED hoses for your PVD. We don't put TED hoses on patients with peripheral arterial disease. Remember that? Those compression stockings, we don't do it for those folks. Only, and they may do it if a patient has hypervolemia, but otherwise for PAD, we don't do the compression hoses, okay? Meticulous foot care, because of the decrease in perfusion, then that patient's at risk for developing ulcers, and especially if they have diabetes. So that's where the meticulous foot care comes in. Right?
Right.
There was something else I wanted to add to that. So just to review some of the other signs and symptoms, we talked about ulcers and it won't heal normally. Color changes of the focal areas of the skin. So if the leg is affected, the foot may turn pale or white with elevation, and that's, you know, kind of known as elevation pallor. If the leg's lowered, then the foot turns red. That's because it's dependent rubor, R-U-B-O-R. So the gravity is working with the blood flow. If they have severe peripheral vascular disease, the leg could potentially shrink and they'll have discoloration in the foot. The other problem that can happen is gangrene can set in. So now is that ischemia, injury, or infarct?
Infarct.
That'll be infarct. So now the tissue of the foot now can become necrotic or die. And so now sometimes they can save the foot. It depends on how bad it is, but they'll either go and remove the gangrene or the patient's going to have an amputation. Okay. All right. So some other minimally invasive procedures that can be done would be the revascularization. So they'll go in and clean that vessel up. Angioplasty, they'll go in with a balloon and they'll actually open up the vessel itself or do it through thermal measures. They could place a stent inside the vessel to keep it open. And this actually has a YouTube video where you can watch that process. From surgical treatment, which is usually rare, but I can tell you that endarterectomy is usually done if the carotid arteries have a lot of blockage in them. So it's kind of like a little roto-rooter where they'll go in and kind of shave out a layer of the plaque so they can get better blood flow to the brain. Bypass grafts, if it's more heart related, yes. So if it's really severe and debilitating, then they'll go in and do some of these surgical treatments. Complications, gangrene, limb amputation, infection, and sepsis. So those would be some things that you need to look for. So you need to look for the foot, kind of having a darkened greenish black color to it for the gangrene. And based on how bad it is, then, the physician will determine if they're going to do a foot and or leg amputation. They do run the risk of more infections because the foot's already a weak area. And because of that weakened area, then, it allows the conditions for bacteria to set in, which if not treated, then sepsis can develop. So diabetes it's asking the question, how would these medical problems affect a patient that has peripheral vascular disease? And I don't care who answers. So how would diabetes affect a patient, or how would this affect a patient with peripheral vascular disease? Would it help it or make it worse?
Make it worse.
Make it worse.
All right, so it'll make it worse. What about renal disease? Anyone but Marky?
Make it worse.
And speak up.
Make it worse.
Okay, so how would renal disease do that? Can't clear toxins. What else? Blood flow, kidney flow.
Blood flow.
Okay. How about high blood pressure?
Yes.
And more specifically, you know, what, and we're going to talk about what is high blood pressure next anyway, but how does that impact someone with peripheral vascular disease?
It's added pressure on the arteries that are already restricted or occluded.
Right. So if you have peripheral vascular disease, then, you know, that person will probably have severe problems with their circulation. As those vessels they're not open enough. So because of that, then we can't get blood flow distally. That's going to impact it. And if you add somebody in there with, you know, high cholesterol, that's going to make it even worse. So in comorbidities is any of these conditions can cause you disability. But if you put them together, it increases your chances of the disability and potentially the mortality related to it. Smoking, what particular agent in smoking is your culprit?
Your nicotine.
It's the nicotine. So nicotine causes vasoconstriction. All right. So I'm going to stop sharing the screen, and then we're going to, any questions before I do that? Before I stop sharing and move on to the next piece.
Was the only medication that you specified the aspirin? What other medications were you?
Lovenox, Plavix.
Your
Actually, Lovenox is intra-hospital. Plavix they'll give outside the hospital.
Is Plavix still something that's focused on patients with stents, or anyone could get it?
Anybody. It's doctor preference. And then you don't forget your Coumadins. Your Coumadin, the warfarin, we don't want to leave them out. So it's back to, I believe it was gas exchange that we talked about, or it might have been when we did metabolism. But in the beginning of the semester back in August, you're like, I've slept since then, so I'm not really sure. But all of those medicines would be applicable meds.
Okay.
Okay.
Mm-hmm.
So any other questions besides those? Okay. So who wants to tell me a little bit about hypertension?
Well, what do you want to know?
We'll start with the definition. We'll start, what is hypertension? How do you get it? How do you know if you have it?
So it's just like a resistance on the blood vessels causing a higher pressure of the blood.
Right. So it's basically the amount of resistance of the blood that's pumping through the body and the artery. So remember, we just talked about vasoconstriction. And so you can the arteries would then get smaller and the blood flow or the pressure inside gets higher. And that higher pressure actually kind of beats up the wall to the point that it loses its elasticity to dilate and contract, or to dilate and to constrict. So it ends up wearing out your in organs because it's not getting enough blood flow. It's not enough going through. And so that's the reason why there's a lot of in organ damage. But the problem becomes when you are, how do you know you have high blood pressure? When do you start experiencing symptoms? You know, your blood pressure goes up. How do you know it's up?
So to be diagnosed with it, it has to be taken 2 consecutive times higher than your normal at a physician's office, or?
Okay. So what is your higher than normal? So if you're going to teach your patient, you know, about blood pressure, what would you say to him or her?
So if normal range is around 120 to 80, 120 over 80, start teaching the ranges as far as what's a pre-hypertensive and what's a hypertensive.
Okay. So I think there's a PowerPoint in your course board, and it talks about the Joint National Commission, but the American Heart Association came back and re-clarified what they consider hypertension to be. And according to the American Heart Association, and I know we've talked about this before, they look at normal blood pressure now less than 120 over 80.
Mm-hmm.
So more specifically, they're looking at it from, you know, 100 to 119 over 60 to 79. That would be your normal blood pressure. When you hit that 120 over 80, so it's basically systolic 120 to 139, 80 to 89 diastolic wise, then for that, you are pre-hypertensive. Then it talks about stage 1 and stage 2. So 1 is essential hypertension, which is primary hypertension. So it's essential and primary are the same. And that's when the blood pressure is between 140 systolic to 159 systolic over 90 to 99. And then you can have malignant or secondary hypertension, which would be anything greater than 160 over 100. So it's greater than or equal to 160 over 100. So we're going to kind of talk through, you know, what those numbers mean. So if your patient does take blood pressure medication, then that individual, we would be expecting to get them down to that 130s range. We don't want them quite down to the 120s, and they may get there, but we don't want them less than that, because now we can actually cause them to develop a stroke, which is, you know, we don't want to do that. We don't want to add more problems to the situation, okay? But overall, it's known, the process is known to be insidious. And insidious is basically by the time signs and symptoms are seen or discovered, permanent damage has already occurred, and that would be to those end organs, okay? So by the time signs and symptoms are discovered, permanent damage has already occurred to those end organs.
Because it's called the silent killer.
Yes, it is called the silent killer, because a lot of folks walk around without even knowing they have high blood pressure. I mean, if you get a headache and it just kind of happens out of the blue, the first thing that your mind isn't leading to is, oh, this is high blood pressure. Or even if you have about a dizziness, you will probably find 5,000 other things to substantiate that dizziness before you get to the blood pressure. So a lot of folks do walk around with that condition and not even having a clue, you know, how it has negatively impacted their life. But the problem is when you don't realize or discover that you have high blood pressure, then the key things that can happen to that person is a stroke, kidney failure, heart attack, heart failure, and they can potentially die. So those are some, you know, or they can have also some blindness associated with that, because you have decreased vessels of the vasoconstriction of the optic nerve. So we don't want to, you know, you don't want to say, well, you know what, high blood pressure is a rites of passage. My mother had it, my father had it, my grandparents had it. You know, your whole bloodline can have it, but it doesn't necessarily mean you have to have it. So you just have to think about those things. And the same thing with your patients. Sometimes patients make decisions and it's definitely not the right one, but they make it anyway. And, they may not go and see the physician. And so now, they're like, well, everybody in my family had it, so they're still moving around. I should be A-okay. And 10 years later, the person has a significant bout of heart failure to the point where now they need a heart transplant. Okay. So it does increase the risk of coronary artery disease, of hypertension, and it also increases the overall mortality of the individual, especially if the hypertension is uncontrolled. If you would have to guess how many people in America have high blood pressure that's at least 18 years of age and older, what would you say? What would you think that number would be? How many thousands or hundreds of thousands, tens of thousands? How many people would have it?
At least 80%.
So give me a number, like in thousands, millions, billions, trillions. That's what I'm looking for.
I don't know. I just read on the PowerPoint and said 30%.
About 67 million people have high blood pressure that's 18 years of age and over. I mean, it's just mind-boggling. And 36 million of those people have uncontrolled high blood pressure. So there's your 30%. That's your 30% of the uncontrolled. So just some things to think about. And cardiovascular disease is the #1 killer, by the way. What ethnic group is more prone to develop high blood pressure?
African Americans.
African Americans. Still, it's prevalent in Hispanics and Asians as well. So causes. We can have heart failure, overworking the heart muscles because of the narrowing and the backflow, can't move the blood forward as a forward pump. You can end up with left ventricular enlargement, right? Mm-hmm. Because that muscle gets a lot thicker, although it's normally thick because of this extra workload that's placed on it. Then you can have left ventricular, they actually call it hypertrophy. It would be the correct process. I've already talked about the other complication would be a stroke. So weakness and narrowing of the vessel can actually rupture the vessel, or you can develop a clot. You can also end up with renal failure, so decreased blood flow because of the narrowed vessels from the hypertension. And then we also have, because of the increased pressure, the kidneys become weaker and the arteries decreases their perfusion. And then you can have vision disturbances. That's why you have the blurred vision. So that individual can have damaged blood vessels to the retina, and that's why the individual can end up blind. Okay. So what are some other risk factors? What will be risk factors for developing high blood pressure? And we'll start with primary, which is essential hypertension. How do we get that one? Is it idiopathic, or do we have a pre-existing condition? How do we develop primary hypertension?
Smoking is one cause.
Okay.
Age, obesity.
Obesity, yeah.
Okay, so smoking, obesity.
Family history as well.
Okay, family history.
High cholesterol.
High cholesterol. So increased sodium intake. So all those processed foods that we talk about, like that college student meal, ramen noodles, that high salt content, deli meats, processed meats, canned goods, alcohol intake can also do it. Stress. Mm-hmm. We talked about family history, advanced age. So as we talked about the arterial sclerosis, so then the vessels kind of get hardened. High cholesterol. Someone talked about obesity, too much caffeine, couch potato. So, lack of activity. Sleep apnea can also lead to that as well. So, you know, if you don't go to the doctor, say if you didn't go to the doctor for 10 years, or if you hadn't been in I don't know when, but your job is stressful, you travel all the time, you eat bad because you're always eating out, all of those things can bring about, you know, high blood pressure. From a environmental process, if you salt your foods before you taste them, then that's another method of increasing salt in the body and potentially developing high blood pressure. Okay. From someone to get secondary hypertension, they actually have to have a pre-existing condition. First and foremost would be pregnancy-induced hypertension. So if the pregnant folks, that's a risk factor, and Ms. Pritchett will probably talk about that on Tuesday. Cushing syndrome, chronic renal failure, diabetes, and either hyper or hypothyroidism, either one of those can lead to secondary hypertension. So the difference between primary and secondary is primary has an idiopathic standpoint or idiopathic development, where your secondary is from a pre-existing condition. Okay. All right, so some other factors that can influence someone developing high blood pressure would be activation of the sympathetic nervous system. And when you're stressed and you have a lot of anxiety, you are literally turning that system on all the time. So it never has a turn down period. So that means that sympathetic, the adrenaline being released into your blood, adrenaline causes vasoconstriction. So if you are that high strung, anxious person, then your vessels are constantly being constricted. Reabsorption of sodium chloride and water by the kidneys, if that's increased, if we have increased activity of the renin angiotensin system. So remember, if you know the renin converts the angiotensinogen into angiotensin 1, angiotensin 2 converts into angiotensin 1 converts into angiotensin 2 by the use of the angiotensin converting enzyme. You all remember that? Okay. So that conversion from 1 to 2, which happens in the lungs, even though it happens in the lungs, it vasoconstricts all those vessels, but then it also has aldosterone release. What does aldosterone release? Salt or sodium. And so we end up with sodium and water retention. Mm-hmm. So you got to go back and trace that all the way back. Okay. Insulin resistance, and that's going to be because of the diabetes actually creates a real, it's like it makes the vessel walls really, really thick and sticky. So that blood flow through becomes kind of turbulent as well. So it decreases the lumen size. So, is there anything else that you can think of that we may have missed? So what are tell me the 5 target organs that would be concerned with hypertension.
Your kidneys,
brain,
eyes.
Okay, eyes, heart, anything else?
Your liver.
In what way?
Because your liver filters your blood, your lymphatics, like all of that goes through the liver. So if you're still at a high blood pressure, wouldn't that affect it?
I could see more kidney than liver. I can see it affecting your clotting factors though. You know, if you're having vasoconstriction to the liver, I could see that. All right. So we already know that it's usually asymptomatic. Blurred vision, headache, chest pain, nosebleeds. We didn't talk about that, but the patient can have nosebleeds as a sign of that individual developing or having high blood pressure. So, sometimes a nosebleed just really isn't just a nosebleed. Dizziness and ringing in the ears. What's that medical term for ringing in the ears? Tinnitus. So we want to assess, we want to educate the patient, and then we want to evaluate. Sometimes you may want to take a pressure in both arms just to make sure there's not a difference. Get family history, any type of sensory changes, BMI. If the blood pressure readings are elevated, make sure, the appropriate folks know. Review medications with the patients. Ask if they're taking it on a regular basis. Some patients are just finding out they have high blood pressure they never knew, and they go to the emergency room because they have a headache or a nosebleed or whatever the case may be, and they're now being newly diagnosed with hypertension. Okay, so we still want to do our assessments, get a nutritional history, their activity level, see what they're doing there, urine-wise. We want to make sure the kidneys are working fine, get our, not our cholesterol, but our chemistry, the CMP chemistry panel. So just a basic chem level, and we can get cholesterol levels and check their ECG. Making sure we don't have any other issues going on. Smoking affects the vessels, so it can make them really hard and stiff. So we want to make sure that we're, stopping smoking cessation, educating our patients about how to lose weight for those that have a high BMI, reducing alcohol intake, reducing sodium intake, moving around a little bit more. So instead of, doing princess parking, do, at the back of the parking lot parking, getting up and moving around in between commercials instead of sitting there looking at, the food commercials, and the next thing let me go in here and see what I can find something to snack on. So all of those things do play a role. Checking blood pressure on a regular basis to make sure that it is within normal limits. Okay. Remember we talked about that DASH diet. So it's the diet, to help decrease sodium intake. So kind of the dietary approaches to stop hypertension. That's what DASH stands for. So what fruits would you recommend, or what vegetables, or, what would you recommend for as far as nutrition?
Fresh fruits and vegetables.
Mm-hmm. Low-fat dairy products.
Avoiding pork products.
Okay, pork products, yep, because they cure that in a lot of salt.
Red meat.
Not so much red meat. But, I would say if you're going to do red meats, do leaner meats. Then if you're going to do hamburger meat, don't do the 80 or the 70-30. Maybe do the 90-10. And you don't have to do it all the time, but just every now and again, incorporate something a little bit more healthy. A lot more chicken, fish, and turkeys. So that would be a good thing to do. Trying to see anything else you can think of related to the DASH. So let's look at some meds. If they're newly diagnosed, we're going to do the DASH diet first. They're going to try to treat them with food and with diet and exercise, right? And they'll do that for about 1 to 3 months, and they'll continue to monitor the patient's vital signs or blood pressure. And then if need be, they'll start them on medications if the blood pressure hasn't come down with all of the other non-pharmacological methods. Once they do start them on medications, they kind of start them slow and then they add on. So they just don't give them a whole bunch. They start them off a little slowly and then they add on from that point. What's usually the first medicine they start them with?
A diuretic.
They start them with some type of thiazide diuretic, and thiazide is THIAZIDE, so thiazide diuretic. And we've seen this before in the HCTZ, the hydrochlorothiazide. So anything that has IAZIAD, that's going to be a diuretic. So when you see that on a medication bottle for your patients, understand that that's going to make them pee off that extra volume that they're retaining. So we need to monitor a couple of things, because if they're increasing their urinary output, what else is also being lost in that urine?
Sodium.
Electrolytes.
Potassium. Potassium is going to be our big issue. So we want to make sure that we're monitoring them for low potassium levels or for hypokalemia. And if they had it, then on that ECG, they would have those U waves, right? So kind of tying back fluid and electrolytes to this lecture. So we want to educate the patient on consuming enough potassium and taking potassium supplements since those thiazides or azides are potassium wasting medications. So like your loop diuretic would be another one, furosemide. So they're going to remove water, sodium through the kidneys and waste our potassium. If a patient's on lithium, we're going to watch them for lithium toxicity, okay? Then we have our ACE inhibitors. That's usually kind of our next in line. These medications end in the suffix pril, P-R-I-L, like lisinopril or enalapril, and those are your ACE inhibitors. So they're basically going to prevent that conversion of angiotensin 1 to angiotensin 2. So it blocks that process, or it blocks those receptors. So for these patients, we're going to educate them about developing a dry mouth or a dry cough, and to avoid potassium substitutes or things that retain potassium, because this medication can cause the body to keep potassium versus lose potassium. And although it's a blood pressure medication, the way it affects that electrolyte, it's more of potassium retention. We need to educate them about compliance. We don't want them to kind of want to skip a few and take the medicines. So if they stop, then their blood pressure is going to return. They call it rebound hypertension. The other thing, if they have an ACE inhibitor with a thiazide medication, do we want them taking it at night?
No, during the morning.
We want them taking it as early in the morning as possible, so that way they can make it to the bathroom. Otherwise, they're going to be up all night long peeing if they have one of those diuretic medications that they're taking at night, okay? If they're taking captopril or Capitan, which is another ACE inhibitor, then they need to take that medicine 1 hour before meals. That's the best way to take it to increase its absorption. Next, we have ARBs, or angiotensin receptor blockers. And so these usually end in sartan, S-A-R-T-A-N. Patients can take it when they can't take ACE inhibitors. Okay, that's my phone ringing, I apologize. Just 1 second. I think that's the last ring. Hang on. All right, that's silly. Okay. So when patients can't take an ACE inhibitor, then they can take an ARB, which is an angiotensin receptor blocker med. So it's going to block aldosterone. So what does aldosterone do again?
Causes the reabsorption of sodium.
So it causes the sodium to hang around, and sodium and water usually hang out together. So it also blocks the angiotensin. So it doesn't allow the second action to happen, and it doesn't actually, it takes care of the angiotensin as well. So it decreases the angiotensin and to renal failure. So we're going to watch the renal function and the potassium levels still. So when you take an ARBs, two things you look out for is kidney function and potassium. All right, the last one I think is calcium channel blocker. So we have a slowing of the influx of the calcium ions. And usually those medications end in DIPINE. So like nifedipine, that would be an example of a calcium channel blocker. Cardizem is another one, or diltiazem. Norvasc is another calcium channel blocker. So it's designed to decrease the workload of the heart, which and also cause vasodilation. So that's how they decrease the blood pressure. The concern when you're giving them this calcium channel blocker, since it does decrease heart rate and decrease the workload of the heart and cause vasodilation, is the patient potentially developing bradycardia. Questions?
Will you be watching for low calcium levels as well?
No, it's a calcium channel blocker. So it's just going to slow the influx of, and we're speaking ionically from the heart process, not for osteoporosis, not for that one. Does that make sense? The only other one I didn't talk about are your beta 2 agonists or your beta 1 agonist meds. What are those known as?
The LOLs.
The OLOLs, OLOLs, which are your beta blockers, right? So metoprolol, labetalol, atenolol, those are all those medications that would that fall underneath the beta blockers. So that's that. When you look at the VCR that I put up on the board before, this would be that second one. So it's going to normally beta receptors increase heart rate and increase contractility. So normally your beta 1 receptors will increase heart rate and increase contractility. But if we block it, then we're going to decrease heart rate and decrease contractility. So we're going to block those sympathetic nervous system effects. So that person's going to have a slower heart rate, and they're going to have a less force of contractility, but overall they're reducing the workload of the heart is what they're doing. There is a caution in patients that have diabetes and beta blockers. We want to check their glucose and monitor them because it will mask the signs and symptoms of hypoglucemia or decreased glucose in the blood. And it's also going to decrease their ability to have tachycardia when they're taking beta blockers. So the heart rate will not go up. The other effect of beta blockers is orthostatic hypotension. All right. So if you have an elder adult or middle-aged adult, then like greater than 60, we're going to keep our focus on their systolic blood pressure. If it's greater than 150, for folks between 30 and 59, not 159, but 30 and 59, we're going to focus more on the diastolic that's greater than 90. So that's our concern when we're looking at high blood pressure. What's the worst case scenario of, what other condition can they develop besides high blood pressure that's really concerning in a medical emergency?
Like a crisis or a malignant hypertension?
Right. They can develop hypertensive crisis. And what would the blood pressure have to be for that?
Usually above like 220 over 140.
Right. So anything greater than 180 over 120. And they need to get that down quickly to prevent damage to the target organ. So this is actually a hypertensive emergency. We don't want to monkey around saying, okay, the blood pressure is high, we need to do something quickly. And we don't want to elevate the legs, because if we elevate the legs, what's going to happen?
It's going to put pressure on the heart because of the blood's returning.
It's going to actually increase the blood pressure, because usually that's what we do when patients are in shock. We elevate the legs, so we don't want to do that, okay? So our goal at that point is to reduce the blood pressure by 25% within the first hour, and then reduce it to about 160 over 100 over 6 hours. And then continue that reduction process to normal over a period of days. So we kind of get them down quickly, but then we slowly decrease that BP. So medications that you may give them would be a vasodilator like Nipride. And if they're on, which is nitroprusside, and if they're on that, then they need to have tight blood pressure monitoring. You can't go in and out of the room. Usually you're right in there. That person should be in the ICU, so they should not be on the floor, not with a Nipride drip, because just a small decrease in their milliliters per hour will cause their blood pressure to drop significantly. That's why they need to be in the ICU and have an art line, etc. Okay. There's other medicines like enalapril or enalapril, nitroglycerin, nicardipine. So those are some other ones that would need to be used to help decrease the blood pressure. But it needs very close and tight monitoring of the BP and their cardiovascular system and how well they're doing. Usually medications will be started on a lower dose and then kind of bumped up. So usually for African Americans, their initial dose is going to be some type of diuretic like the thiazides or calcium channel blocker. If they have high blood pressure with diabetes, then they'll give them thiazide type diuretic or a calcium channel blocker, or they may give them something like Bidil, which is a newer product that they'll give African Americans. So one thing you'll learn is that all drugs don't fit all folks, or all drugs don't fit all ethnic groups. For your non-blacks with high blood pressure and or diabetes, then they'll add some type of thiazide diuretic, calcium channel blocker, ACE inhibitor, or they can do an ARB, which is an angiotensin II receptor blocker. So, you know, they'll try something. If it works, great. If not, then they'll move on to the next one. So those first few weeks, the patient's going to have really tight monitoring, and, you know, that dietary process needs to be discussed to make sure that, you know, they're just not taking in a whole bunch of salt. All right, let's see. I believe your PowerPoint actually had you kind of walk through some nursing diagnoses and interventions. It kind of compared a 70-year-old African American to a 28-year-old Hispanic person. So, you know, just kind of go through that and finish out the teaching plan related to it based on information we've already discussed. So what I would like to do is a case study. And let me find it real quick. And we may have done this case study before, but it warrants going back to since it's been a while. I'm going to share my screen. All right, so can everyone see the scenario?
Yes.
Okay. So we have a 65-year-old African-American woman who comes to the clinic for a follow-up visit. She was diagnosed with hypertension 2 months ago. She was given a prescription for thiazide diuretic, but stopped taking it 2 weeks ago. It made me dizzy, and I kept getting up during the night to empty my bladder. So just reading that, what are some concerns that you already have?
She's not supposed to stop it abruptly, and then she's not taking it at the correct time of the day.
Right, because if she's taking it and getting up at night, then that's a problem. Okay. So in the clinic, she expresses fear because her mother died of a stroke, and at her current age, 65, and she's afraid that she's going to succumb to the same fate. So she's never smoked, and she doesn't drink, but she's, afraid of the high blood pressure, and rightfully so. So here's her family history, her chart history. And according to the Joint National Committee on Blood Pressures, where would she be classified? Her blood pressure. It's 150 over 92.
In a stage 1 hypertensive.
Stage 1, do you all agree? Anybody else besides Marky?
I agree as well.
Yeah, this one.
Okay. All right, stage 1 is correct. So having a blood pressure 140 to 159 for systolic, 90 to 99 diastolic on each of 2 or more office visits, then that's going to be a stage 1 hypertension. And what's the other name?
Essential.
Essential. All right. Question 2. So what could be causing the nocturia?
The taking the diuretic at the wrong time.
Okay, because it does say she's supposed to take it every morning, right?
Mm-hmm.
That's what the orders say. I don't see anything. I'm just scrolling back down. So basically, her mother died at 65, father died at 67 from a heart attack. Her sister's still alive. Her brother's alive. He's 70, but he has same problems. He has comorbidities. She's married, 2 children. They're good. She's had a cholecystectomy and a hysterectomy, so that may be an issue with her blood pressure. So these are her two reports. So now the nocturia could be due to the fact that she's taking this medication in the late afternoon or evening instead of in the morning. So they must be taken in the morning so it doesn't disrupt her sleep. And that's why I brought that up a little bit ago. So as the case goes through, her vital signs are 162 over 102. Is that good?
No, it's elevated. Higher. Sorry.
No, they're not good.
Okay, so heart rate's okay, respiratory rate's okay. Her most recent CMP or BMP, basic metabolic panel, which is basically a Chem6, and fasting lipids are within normal limits. She's 5'4" and she weighs 110 pounds. That's not bad. So she's not obese. So she tells you that she tries to go on walks but doesn't like to walk alone and has done so only occasionally. So what other risk factors is she having?
She's now in hypertension too.
Okay, so she's definitely progressed to stage 2, but they're looking at her risk factors.
Well, she's African American.
Okay, so genetics,
Family history, yeah.
family history.
She's also had the hysterectomy, so there might be some hormone imbalances.
Okay, and I'm just going to scroll back to see if there was anything else in that vignette, to be concerned with. So she doesn't drink alcohol. So just looking at all of the other risk factors that we discussed. She doesn't seem to have any renal problems, right?
She might be a little stressed. She's probably stressing herself out, worrying about having trouble like her mother and father.
Mm-hmm.
Okay.
Charlie said
Anxiety. So Ashley said anxiety. I agree with that. Not active. I agree with, Charlie said anxiety. Ashley said not active. I agree. So those will be some additional ones. That could be another complication. All right, so let's see what else we have. So hypertension, physical inactivity. So the good one, Charlie, or not Charlie. That was Ashley. Over 65, her age. So that's going to predispose you as well. Postmenopausal, Marky, you brought that up. Family history of cardiovascular disease. Her mother died at 65 from a stroke. Okay, so good. All right, so her BP continues to be high. The internist decides to put her on another drug and recommends she try again with the HCTZ. Okay, so that makes sense. According to the Joint National Commission 8 guidelines, what drug category or categories are recommended for NP at this time?
So with that high blood pressure, other than like the diuretic, something like a ACE inhibitor, like do a combo medication.
Okay, so we have combo medication on the table. So usually they do better. African Americans do better with calcium channel blockers. So let's see what the Joint Commission 8. That's what that JNC. So the Joint National Commission. It's crazy that it's dark now at 6:19.
Right. I was thinking the same thing.
Joint National Committee, not Commission. I'm so used to saying Joint Commission. All right, so if you go to aafp.org, let's see if they have a chart. So thiazide, calcium channel blocker, angiotensin converting enzyme inhibitor, and then an ARB. I'm seeing if they have a table.
Would you really want to give a patient that is not having any swelling HCTZ medication?
Well, the reason why her blood pressure is high is because we're trying to decrease some of her sodium issues. Although they're normal, that's another way is to eliminate volume. It doesn't necessarily mean that you only give a diuretic for swelling.
So what was the regimen specifically for African Americans?
It says, this is in general, the non-Black population. Let me find the Black population. Hang on. It says non-Black population, including those with diabetes, initial antihypertensive would be a thiazide. And it goes through to say, we start with a thiazide, or second medication should be added would be calcium channel blocker, ACE inhibitor, or an ARB. Do not combine ACE inhibitor with an ARB. Third drug should be added if necessary. And if it can't be achieved, use a beta blocker. There was 2, so let me go back to
to me, they wouldn't even want to keep her on the HCTZ since she's not even taking it because it's making her dizzy.
Well, she's not taking it because her pressure's high, and that's what's really making her dizzy.
But I guess whenever I first read that, it sounded like she stopped her medication. So how does she know if it's even going to work since she only took it for 2 weeks?
Right. She basically gave up on it. Number one, she was busy, and she just basically took it whenever, and she was up at night. So that caused her to have more problems. So the truth of the matter is, you're right. She didn't give it an opportunity to work, number one. Number two, you know, she needed more education on the medicine and when to do it. I just think they just said, here, take this medicine, take it once a day. And that's what she did. So here, for African descents who do not have diabetes or chronic kidney disease, the guidelines recommend a calcium channel blocker and thiazide type diuretic to be started before any antihypertensive drugs. And if those are not effective, then the guidelines recommend a dose adjustment and/or an addition of either an angiotensin converting enzyme inhibitor, an ACE inhibitor, or an ARB. But they cannot get an ARB or an ACE inhibitor together. So beta blockers, alpha blockers, they're also considered after initial treatment with calcium channel blockers. African Americans are going to get a calcium channel blocker and a thiazide first. Those work better. But once these other ones are not effective, then they will.
Okay.
They'll look at the other meds. So it's not that the medication didn't work. She didn't give it an opportunity to work and she wasn't taking it correctly. That's what that boiled down to. So she goes on to ask whether there's anything else she could do to help. Do I need to lose weight? Well, she's 110 pounds. Does she need to lose weight?
No.
Okay. So for her height and age and her body mass, she's not overweight. Okay. So depending on her BMI in the chart, she would be considered either optimum weight or even slightly underweight. So she doesn't need to lose weight. All right. What non-pharmacological lifestyle alteration measures might help her?
Low sodium diet.
Okay. And why?
Because the sodium is what makes your blood pressure go up.
Okay.
She does need to increase her physical activity as well.
Okay. How about decreased stress?
Which, if she goes on a regular walk, that could help decrease her stress.
Well, she really doesn't like to walk by herself.
Well, she can do things in the home to help with her physical activity. She can do stuff in the house.
I don't disagree that she can move around a lot more. I don't disagree. So let's see. Limit salt in her diet is a good way. And then monitor her BP. If the BP decreases when the salt is withheld, then the person is salt sensitive. And limiting salt might bring about a modest decline in BP. In patients who are salt sensitive, the most effective technique has been the no salt shaker approach. So don't add salt to the food when cooking and don't have a salt shaker on the table. Ultra low salt diets are in general ineffective and might even lead to iodine deficiency. So DASH diet has been shown to be effective in lowering BP, usually within 14 days. So the rich fruits, veggies, hang on one second. I'm so sorry. So the low salt veggies, fruits, that would be the best way to do it. Okay. Low fat diet, low fat dairy products, and low saturated fats. So is it also higher than normal in potassium, magnesium, calcium, vitamins D, E, and C? Dietary changes may have powerful cultural implications. So again, they may need a registered dietitian. Reduce caffeine intake. Alcohol intake can lower BP. Routine exercise, so she can do the walking. She was doing it, but I don't think she maintained it. So long-term exercise compliance is better in individuals engaging in low to moderate intensity exercise. So if you're stiff, sore, exhausted as a result of exercise, you have done something wrong or you've done too much. If you are out of breath during exercise, you are doing too much. So stress management. Makes sense?
Yes.
All right. So as we move on, we give her hydrochlorothiazide 12.5 milligrams daily, and we add a prescription of benazepril, so low tensin. So is that an ACE inhibitor, calcium channel blocker?
ACE inhibitor.
That sounds like an ACE inhibitor. 5 milligrams daily. So she's instructed to return to the clinic in 1 week and have her blood checked, her blood work. She's instructed to monitor BP at least twice a week and return for medication management appointment in a month. So why did the internist decrease the dose of hydrochlorothiazide?
Because she was probably sensitive to it, or it was causing electrolyte imbalances.
She didn't have that because remember her CMP was normal. But when they do combo meds, when they put you on 2 medications, they decrease the dose. Remember that? So that way you don't, they have more room to grow with. But when you add 2 medications together, then you can give them that medication at a lower dose. So then she was complaining of the dizziness, which can be related to the orthostatic hypotension. Elderly may be more sensitive to hypotensive effects, and the dosage adjustment can help reduce the problem. All right, so of all these, education about common side effects, which will include, what will we select for her?
The cough, that's an ACE inhibitor.
Okay.
And then dizziness.
Okay, so B and E, any others? Exercise, okay. Got that. I'm sorry, Charlie, I keep getting to you late. I got to keep checking that one. So how about headache? Headache, cough, and dizziness are common side effects, as well as postural hypotension. So that's basically when they change positions, then they get, the blood pressure drops. Okay. It is sometimes difficult to remember whether one has taken medications. What technique might you teach her to remember her medicines? And give me at least 2.
Like a pill box.
Pill box, and especially one if it has a timer, like if she has to take it twice a day or something like that, then, you have a medication pill box with an alarm system. Any others?
Sit it on the table so when she eats breakfast, she can remember it.
Okay.
Note on a refrigerator.
Calendar, something, right? Okay, so use a day of the week medication holder so she can see whether she's taking it, setting an alarm on your phone. Good one, Ashley. Make a check mark on her calendar each day she takes a pill. Place her medication bottles in an area that's convenient for her, that she's going to see them, like in the bathroom, like when you brush your teeth. That'd be a good place to put it. So there's different things you can teach your patients. Let's see. I think there's a couple more. All right. So after teaching session, which statement by NP indicates a need for further instructions? A, B, C, or D?
C.
Hmm?
C.
That she needs further instructions.
Right.
Correct, Charlie.
C, because you're not supposed to skip doses.
Correct. So was that not her problem?
Right.
Did she skip the other ones?
Mm-hmm.
So soon as skip come out her mouth, somebody should be like, no, no skipping. So skipping is not recommended because it can have rebound hypertension severely. So if she has questions about taking the drug or wants to stop taking it, she needs to contact her physician immediately. Okay. And so here we are a month later. She tells you she's feeling fine. She doesn't have any side effects. She's been checking her blood pressure at the senior center, and those are her ranges. Are we good?
Mm-hmm.
Is that adequate enough? Yeah, she should be good. So when she's taking these two medicines together, what laboratory test would you monitor?
Potassium.
Yep, potassium's one.
Antarbun and creatinine for her kidney function.
Yep, BUN and creatinine. What else?
So,
Anything else?
You could do a whole electrolyte panel since she's doing a diuretic.
Yep, you could do a CMP or BMP. So we're going to monitor potassium levels because, it can cause a decrease, but the ACE inhibitors can cause the potassium levels to increase. So both the drugs can cause sodium decrease and creatinine levels. ACTZ can increase the serum glucose levels and decrease the serum magnesium. All right, so here's our lab values. What laboratory results, if any, are of concern?
Her glucose is high.
It's all right.
For fasting?
Oh, for fasting. Okay, it's on the upper end. It should be between 70 and I want to say 120.
Every reference that I've ever seen is always different.
Well, we'll see. I mean, it may be it. Let's see. We have two people that responded. Hold on. We have potassium. Sorry, not potassium. Sorry. Potassium's fine. Sodium's fine. Is chloride normal? Creatinine looks fine. BUN, I think, is up to 22 or 24.
Isn't chloride from like 95 to 105 or something?
Yeah, so that would be close. It's on the upper end. Maybe nothing. Let's see. Overall, they're normal. So it is elevated over 110. Elderly can have an increase in the normal range of glucose, especially after the age of 50. However, remember that the HCTZ can cause an increase in glucose levels. But, I mean, overall, they were fine. You take the blood pressure, you get 134 over 82. She asks whether the BP readings are okay. And what do you say?
That's still kind of in a pre-hypertensive.
Well, I think that's a good range because you still said you didn't want her to get down too low.
That's correct. That's correct. Compare these readings to the national standards and the goal of which you both agreed. So we don't want them to get too low. We don't want them to end up with a stroke. All right, so 3 important ways you might help them maintain their success.
Continue the same medication regimen.
Okay.
Whatever she's doing, she needs to continue to do because she's doing great now.
Okay. So basically provide some emotional support, be encouraging. Okay. You know, a Texas term is if it's not broke, what? Don't fix it.
Don't fix it.
So tell her you're proud of her. So therapeutic goals are individualized. However, these readings are improved and at the pre-hypertensive levels. So tell her that these readings are improving and that you'll pass them on to the physician. Remind her of the therapeutic goals that she's working towards and review her progress over the past months with her. This is an excellent way to reinforce adherence. Remind her of the necessity to stick to the treatment plan, because if she's doing well, she will more than likely continue to take her meds and then to also check her BP. So that's the way to keep success going. So she recently went to a luncheon with her garden club girls, and you know that most of the women take their different blood pressure pills than she does. She asked why, the different shapes and colors. So how can you explain the difference? Different strokes for different folks?
That medications just affect people differently.
Different drugs are used to treat blood pressure, high blood pressure. So they're to find the one that controls their blood pressure the best and have the least side effects. Everyone's individualized. You know, their medical history, tolerance of meds, so that, you know, they may find that her friends are on different ones. Many drugs have generic versions, which is another issue or concern, not really a concern, but another point, with different dosages and formulations. So all of these will have different shapes and colors. So the same drug may have several different appearances. So this can be confusing. So patients should always double check with their pharmacist to make sure that there hasn't been a mistake in their medication if their medication looks different. So the doctor asked about our last eye exam. She says, I'm not sure, probably 2 years ago. What does that have to do with my blood pressure? What is your response?
High blood pressure can damage the optic nerve and cause vision problems.
Okay. So it can affect the vasculature of the eyes, damage the vessels, and may result in blindness if it's not controlled. So they need to have regular eye exams at least every year. Her outcome is 3 months later, she's doing fine with the drug regimen. Her average BP readings are 130/78. She's going to the senior citizens group walking program at the local mall, and she admits she has not done as well with decreasing her salt intake, but is still trying. So if she tells you that, do you harp on her about the salt? What do you tell her?
You don't do that because she's still doing really good with her blood pressure.
Okay. So basically, you still be encouraging, you know what, one step at a time, baby steps, continue to work on it. Okay. Any questions, comments, concerns with this case study? All right. So I'll stop sharing screen. And are you pooped or you up for another?
I'm up for another, but
Another.
You guys are cracking me up. All right, so let's do heart failure because we did talk about one of the side effects of not treating your high blood pressure can lead to heart failure. And I think your PowerPoint may say congestive, but they've kind of moved away from the congestive part. So heart failure is basically when the heart's just too weak to effectively move the blood forward as a forward pump. So it can't provide cardiac output to maintain the body's metabolic need. So the heart muscle is functioning well, but the pumping of the blood through the heart valves or through the heart pumping contractions or the contractions of that have been compromised. The ventricles are usually both thickened, so the right ventricle and the left ventricle. So here we have an impairment of the myocardial function. So the valves could be faulty. This is the reason why we're going to talk about prolapse cord, or I keep saying prolapse cord, but I meant prolapse valve. Prolapse cord is an OB thing, so disregard that. But we're going to talk about the mitral valve prolapse. Usually the valves that are involved are going to be the tricuspid and the mitral valves. They become narrow or stenosed, or they can leak, and that's what causes regurgitation. But this is going to increase the workload of the heart. They can also develop heart failure due to arrhythmias like atrial fibrillation. And what happens there is the atria just fire, and they fire at a rate of about 300. But the ventricles cannot let all of those impulses go through. So what usually happens is the blood usually gets left behind and becomes stagnant, and it can form clots and make the heart just work harder to function. Any tachycardia where the heart doesn't empty and fill can also, make the heart work harder and end up in heart failure. Myocardial infarction or a heart attack secondary to coronary artery disease is another an example of an impaired myocardial function. Rheumatic fever or an infective endocarditis where some type of vegetation has gotten onto the inner layer of the heart muscle, that can also lead to heart failure. Family history, so your genetics, that could be a reason why a person develops heart failure. Uncontrolled high blood pressure, it weakens the heart muscles and makes the heart more stiff. Recreational drugs like cocaine and alcohol, and actually cocaine can literally stop your heart. So forget about having heart failure. And things like viruses or infections that can attack the heart muscle. So those would be some of the ones that when you're looking at etiology or etiology that can lead a person to develop heart failure. Some things that you can think about is the more stretch, there's a law that talks about the more stretch you have on the heart, the more contractility happens, or that you have a better contractile force. What is that mechanism known as?
Cardiac output?
Well, it does increase cardiac output, but it's Frank Starling's law. So Frank Starling's law basically talks about the more you stretch the myocardial fibers, the better the force of contraction of the heart occurs. But this also increases the workload of the heart when that happens. Some other compensatory mechanisms that can be utilized is ventricular hypertrophy. So what that means is the ventricles will thicken, and it will also cause an increase in myocardial oxygen demand and cellular enlargement. But the heart size normally increases because it's trying to exert that blood flow out into the aorta, and it needs to have enough force for that to happen. And if it's not available, then eventually the heart, in a lack of a better term, will poop out or tucker out, whichever one you want to use, and the patient will develop heart failure. Backflow will start to happen into the pulmonary vein and going back into the lungs, okay? How the neural system responds, the heart rate goes up, blood pressure goes up, and this will, in attempt, increase contractility, but that also increases workload. The renin-angiotensin system, it will try to redistribute the blood through the body, so it'll cause a decrease in renal perfusion, increase preload and afterload. Your PowerPoint gives you a little video to look at, and it actually does. It's a very good video, so I highly suggest you do it. Risk factors for heart failure: coronary artery disease, high blood pressure, family history, cardiotoxic drugs, smoking, obesity, alcohol abuse, and diabetes. There's several types or different types of heart failure. So you can have a systolic versus a diastolic. And diastolic, the heart doesn't completely relax. In systolic, the ventricles fail to adequately contract the blood or eject the blood forward. Left side versus right side. Left heart failure is related to heart disease and hypertension, and it can also be related to an MI. So a patient having a myocardial infarction or heart attack, where right heart failure is related to pulmonary disease. So acute versus chronic. Acute means it happens suddenly. So chronic would be someone that actually has a disease of the heart muscle itself known as cardiomyopathy, where they have a sudden onset of shortness of breath at night, which is known as paroxysmal nocturnal dyspnea. Low output versus high output would be low output is coronary artery disease, high blood pressure, and cardiomyopathy, where high output would be related to hyperthyroidism, infection, anemia, and pregnancy. So all of these things, I mean, there's a lot of stuff that's going on or can happen or cause heart failure. So right-sided, you know, you're getting the blood oxygenated. Your inferior vena cava is connected to the hepatic vein of the liver. The left ventricle has the most pumping power of all the chambers. So either a contraction problem or it's not filling properly. Left-sided, the ventricles are too stiff or they don't contract appropriately. So the blood kind of backflows to the lungs. Therefore, you see the pulmonary signs and symptoms of rales, orthopnea, and dyspnea. And orthopnea is laying somebody flat, but they're short of breath laying flat. Right-sided, it backflows the blood back into the superior vena cava and the inferior vena cava to the peripheral areas. So now we see the whole right side of the body that's going to develop fluid or edema. So we're going to have dependent edema or peripheral edema. We're going to see weight gain. They'll have sacral edema. The belly's going to get really big because the liver's going to have difficulty processing that problem, and it's going to now collect fluid into the stomach known as ascites. So ASCITES, ASCITES. The liver's also going to be swollen, so it's going to get bigger in size. And that's going to actually trail over to the left side where the spleen is also going to become edematous or is going to increase in size as well. A lot of times they base heart failure on a patient's ejection fraction. So they'll get an echocardiogram. And that ejection fraction is the amount of blood that's filled inside the left ventricle that's being contracted out. So normal is 50 to 70%. When the ejection fraction is less than 40, then that person is said to be in heart failure. So it's a calculation tool that's used to measure and diagnose how the left ventricle is functioning, its ability to pump blood out. So if the ejection fraction is 38%, then only 38% of the blood that filled in that ventricle is what's existent there. So they can go to cath lab to be diagnosed with it. But only that blood that's there, if it says 38%, that blood is what's being pumped out. So you're not getting the whole 50 to 70% of the normal. Any questions on that piece? So you have to know the numbers in order to figure out the ejection fraction. But when it's less than 40%, that person has heart failure. The other manifestation of left heart failure, and which one do you think you'd get first, left or right? If you had to guess.
Right, because it's intertwined with the respiratory.
Okay. So usually respiratory would be like your COPD. So when they're saying respiratory problems, they can develop cor pulmonale. However, it's actually left side that's going to back up into the lungs first. So that's usually the first one where they have fatigue and activity intolerance, shortness of breath, the crackles, the gallop. So that would be the abnormality there. And then usually left-sided heart failure causes right-sided heart failure, but not all the time. So you can develop right-sided heart failure without having left. And at times you can have both left and right. It just depends. So right-sided, as I said, you'll have the edema to the feet and the legs, the nausea, the liver engorgement, which is the hepatomegaly. They could have nausea, vomiting, diarrhea, splenomegaly, ascites, weight gain, so sacral edema, all that GI congestion. So with right-sided, they're kind of, they're just swollen, for lack of a better word. Neck veins, they have JVD or jugular venous distension or engorged neck veins, however you want to put it. They're lethargic, they're tired, they have difficulty tolerating activities, they have irregular heart rhythms like AFib, so they're urinating frequently at night. The fluid fills in the vascular system, goes to the kidneys and start putting out fluid. For left, they do have weight gain, but they're actually drowning because now they have the fluid in the lungs. So they have the rales and the orthopnea, the weakness. They can get up and pee at night as well. The nocturnal paroxysmal, shortness of breath, not nocturia, sorry. Increased heart rate, a cough, and weight gain. And usually that weight gain is 2 to 3 pounds in a day or 5 pounds per week. Is that good or is that a red flag?
A red flag.
That's a red flag. So anytime a patient says, I've gained 3 pounds over the last 24 hours or I've gained 7 pounds in a week, then you should be like, okay, we need to do something. That's too much water weight or too much fluid. So left and right, although they are heart failures, but they have different presentations. They're not the same. The other thing I want to talk about is a BNP, which is a
Brain natriuretic peptide.
a biomarker that's released by the ventricles. It's the beta natriuretic protein, I believe.
Brain
Natriuretic protein. And basically that lets you know if the person has heart failure as well. As a, not protein, but it's a peptide. Brain natriuretic peptide. And so if it's greater than 100, heart failure is present. So less than 100, the patient has no heart failure. 100 to 300, it's present. Greater than 300, heart failure is mild. Greater than 600, it's moderate, and greater than 900 is severe. So less than 100, no heart failure. 100 to 300, heart failure is present. Greater than 300, we have mild heart failure. Greater than 600, we have moderate heart failure. And greater than 900, it's severe. So we want to look at the BNP, the electrolytes, the UA, the LFTs, which are the liver functions test, thyroid, get an ABG, chest x-ray, echo, maybe send them to the cath lab and do a nuclear stress test. So usually they do the BNP, or B as in boy, N as in Nancy, P as in Paul. It's done when the patient has a history of shortness of breath and they're trying to determine whether or not they do have heart failure. So your PowerPoint talks about the different stagings of heart failure, A, B, C, and D. So don't forget to read that. I don't want you skipping over it. Like, well, okay, it's A, B, C, and D. You need to know what those are, but just understand that D is definitely refractory. And you have symptoms at rest despite treatment. So your heart failure can be triggered to exacerbation, and that's when the patient eats, high levels of sodium. They don't restrict their fluid, so they're drinking a bunch of water, a bunch of soda. If they have an infectious process, so the illness will stress the heart out. If their atrial fib is not controlled, or if they have renal failure. So of those 5, which one would be considered the patient not being compliant?
The dietary measures.
So the dietary measures, eating excessive salt and not restricting their fluid and soda intake. So non-pharmacologically, we're going to maintain with medications, diet, and other treatments. So basically, we're going to try to modify some of the things of what they're doing. And they do consider high blood pressure to be a modifiable disease if people follow the right regimen. So things we need to do is make sure we're assessing patients appropriately. We're just not skipping over body parts. We're educating your patient, and we're giving medications as we're supposed to. So we're watching and monitoring for the patients getting worse. We're looking for, you know, if the peripheral swelling was on the right side, if they had right-sided heart failure, if the peripheral swelling was like, you know, 1+ edema, and now it's like 3+ edema, is that good or bad?
Yeah.
That's bad. So those are the things we're looking for, and we're making sure that our patient is getting better and not worse. For the left side, we're looking for an increase in rales, which is the reason why we need to auscultate lungs posteriorly and not just anteriorly. We need to check the back side, especially if they're laying back, then that fluid's going to shuffle towards the back, okay? And you can have clear breath sounds here anteriorly, but have rales halfway up, 3/4 of the way up posteriorly. So you just can't listen to the front. You have to check the back side as well. If the patient is responsive to medications, then, you know, we'll look at their heart rate. We're probably put them on some digoxin. And digoxin, we need to make sure that we check their heart rate before we give it, right?
Mm-hmm.
What should their heart rate be?
Greater than 60.
Has to be at least 60, because it's gonna make it go lower. So if their heart rate's 58, can we give them the digoxin?
No.
Absolutely not. So digoxin actually slows the potassium and the sodium in and out of the heart cells. So this causes an increase in calcium inside the cell. So that was going to, when that calcium is increased inside the cell, it slows electrical signals and it decreases heart rate. So to monitor the blood pressure, they may get an ACE inhibitor, an ARB, or some type of vasodilator. And to monitor the volume status, they may get a diuretic to remove the fluid. So if they get that, then what would be some nursing actions we need to do?
You need to monitor their weight, their INOs.
So we're going to monitor their weight, their INOs. We're going to do strict INOs. So if they don't have a Foley place, then we're going to give them a hat and have them pee in that hat so we can keep track of it. You know, drain the urine. You know, activity may not be tolerated. We got to pay attention to that. Do daily weights. Outside of DIG, we can also give them a beta blocker so that we can give them that as well as a medication. For labs, we're going to be more concerned with their BNP, so that brain natriuretic peptide, the BUN and creatinine for the kidney functions. We'll check troponins, and that's to make sure the patient's not having any heart attacks or anything like that. Check our potassium levels, especially with the diuretics, for either hyper or hypokalemia. So, you know, if they're on a potassium sparing, if their potassium is low and they're on DIG, then we have to be concerned about DIG toxicity, right?
Mm-hmm.
So anything that's going to cause, you know, potassium wasting. ACE inhibitors and ARBs actually increase potassium. So we need to monitor for that. Safety, getting out of the bed, fall precautions because of the orthostatic hypotension. Swollen feet, difficulty walking. So all of those are going to put them at risk of falling. We're going to make sure they have, you know, follow a cardiac and fluid restriction diet. max that they should be able to drink would be 2 liters per day. So, and no cheating. The edema, we want to keep their legs elevated. So high Fowlers to help with breathing when they're having a flare up, but we want to make sure we help decrease the swelling as well. Know your drug categories for heart failure and how they work, how they work on the body. So we want to make sure that, we understand those components. So, oh, sorry about that. Go ahead.
I was just, through the PowerPoint and another one of our books, I've seen where it says to not elevate the legs when they're sitting versus to elevate the legs when they're sitting. One says don't do it because it promotes venous return and added pressure to the heart, and the other one says yes to do it because of edema. So how do you decipher to do it or not to do it?
I would monitor my patient and see how the patient's doing before I determine whether I'm going to put it up or not. It's not a one size fit all. This kind of is that gray area. So you always look at your patient and you determine, do I need to elevate the feet or not? So if my patient's struggling and they're short of breath, I'm not going to elevate the feet because it's going to encroach on their ability to expand their lungs and they're going to have difficulty breathing. But if my patient is not dyspneic, then I can elevate their legs because now they're not short of breath and there's no complications. Does that make sense? So if you elevate the legs and you try to elevate their body forward, then basically you're shortening the trunk. So if you just elevate the leg, if their breathing is okay, their respiratory status is okay, then elevation of legs would be A-okay. But if they're having respiratory compromise, then I wouldn't elevate the legs. We can work on that by giving them some Lasix before we do anything else. So medications, ACE inhibitors, remember we talked about that. So we want to make sure we tell the patients about the potassium, or in changing positions, but when they change slowly to decrease the potential of dizziness. That's going to be the first line of treatment, is going to be the ACE inhibitors. Then we have our ARBs, the angiotensin II receptor blockers. That'll be our Diovan and our Clozar. And the ones that usually use for heart failure is going to be Capitan or Vasotec, which is enalapril. They'll use enalapril, Vasotec, and or Capitan. Beta blockers at a low dose, they'll give them Coreg. And I know some of you all have passed Coreg in the clinicals. Diuretics, they'll give them Lasix or Bumex to decrease the blood volume and to help decrease the crackles by pulling off the extra water. And then a positive inotrope, which basically means an inotrope is a medication that increases the contractility of the heart, or increases the force of contractility. So you'll have chronotrope, which that focuses on the patient's heart rate. Inotropes focus on the contractility of the heart, and dromatopes focus on conductivity, or the conduction of the impulses. So if you have something that's a positive inotrope, that means it's going to increase. If you have something that's a negative, that means it's going to decrease. So here, digoxin is a positive inotrope. It actually increases the force of contraction by increasing the intracellular calcium concentration. So it's usually used with an ACE inhibitor and diuretics, but we still have to be mindful about toxicity effects, etc. So like nausea, vomiting, vision changes, if they start complaining of green halos, and this is with the DIG that we're speaking of, then they need to seek a physician, or we need to call the MD. And so the antidote for that would be Digibind, Digibind, to help decrease the effects of DIG. But normal levels are 0.5 to 2. And so if it's, over 2, then that person's toxic. So nausea, vomiting, headache, belly pain, visual disturbances, double vision, blurred vision. On the ST segment of the ECG, it's going to have like a scooping, so you can almost, it'll look like you can put a little pill on the inside of it. AV block, sinus brady, supraventricular tachycardia, PVCs, those are all additional ones. But usually the hallmark sign is that scooped ST segment. So it's kind of spoon shaped, right at the, where it's almost like you put a pill inside. Other treatments would be a balloon pump, so an intra-aortic balloon pump, and very seldomly will you see patients on an IABP unless they're ready to go for a heart transplant. And that requires, you know, training, a certification, et cetera, to monitor those. A ventricular assistive device may be used, and then the other treatment, as I just spoke of, is a heart transplant. So if your patient has, you know, weight gain or increased weight gain of 3 pounds per day, then you need to contact the PCP. Education-wise, prevent readmissions. So take the medicines as you know, prescribed. You know, making sure they monitor their weights, making sure they're decreasing their sodium intake, etc. Follow the low salt diet. You know, only 2 to 3 grams per day. That's the max they should have. No canned goods, no frozen meats, no deli meats. They need to cut all that out. Only 2 liters per day on fluids, so they can't, you know, drink a whole bunch of Texas tea, that, what is that, red ribbon or red somebody. Vaccinations, they need to make sure they get their annual flu and pneumonia shots, because illness can worsen their heart failure and stress the heart out. Move around a little bit, do some low impact aerobic exercises to help, you know, strengthen the cardiac muscle. Do their weights daily to see if they've had any weight gain. So 2 to 3 pounds per day or 5 pounds per week, that's a concern. Make sure they're compliant with their medications and that they're not smoking and drinking a whole lot of alcohol. Watch for signs and symptoms of early heart failure. So shortness of breath with activity they used to be able to do without problems. Orthopnea, do they need now, you know, 5 pillows where before they were only using 3 pillows? So now they need more pillows to sit up to prevent shortness of breath and weight gain. All right, so let's do this case study, and then this will be it for the night, because that'll be about 2 hours. We're already at 2 hours, so it'll take us 2.5 hours. Share my screen, and all right, so here we have Miss Smith. She's admitted to the emergency room with heart failure. She was discharged from the hospital. She complains of not being able to catch her breath. She has 4+ swelling in her legs. Is that good?
No.
Based off of this small amount of information, do you think she has left or right heart failure?
Right.
Right, because of the edema.
Right, because of the problem, more than likely right due to the edema. So she states she's been following the salt diet restriction that her physician told her, you know, to do. She's gained 10 pounds since discharge. Okay, that's a lot.
Oh yeah.
I'd like to know if that was in a week, 2 weeks. It doesn't give me a time frame. It just says she was recently. So she still may be A-okay. We got to wait. Vital signs, she does have some respiratory struggles. She's breathing at 28. BP's elevated. And she's on room air at 91%. Is that good?
No.
No. So she's on Vasotec. She's on DIG. She's on potassium. She's on Lasix. And the physician writes for all the meds, but changes the Lasix to 80 milligrams IV push now and then 40 IV push per day. Okay. And why are we giving her that extra bump of Lasix?
Take off the weight.
Okay, because of the weight. All right. So what error in discharge teaching likely occurred?
She should have reported the weight gain when it got to 3 pounds.
Okay. So there's a potential that she says she's been following the fluid and the diet restriction. Okay. So something's not going right. So failure to instruct the patient when to call regarding the blood pressure, heart rate, edema, shortness of breath, and weight gain. Because she complains of not being able to catch her breath. So they missed that. The edema, the swelling, the weight gain. Her heart rate is, I missed that. I don't see, I don't see a heart rate. I see a BP and a respiratory rate. All right. What's the rationale for changing PO to IV?
The absorption rate is faster.
Absorption rate's faster. Okay. So to pull more off due to its potency, and there may be bowel edema, which would inhibit the absorption of the oral Lasix. If we're thinking she has right, remember I said there's a lot of GI swelling.
Mm-hmm.
All right, so you give her Lasix, and what are the parameters you need to use to monitor the effectiveness of the drug?
Her in and out.
Her INOs. That's the effectiveness of the drug, because Lasix is a what?
Diuretic.
It's a diuretic. So we're going to monitor INOs, her blood pressure, skin turgor, daily weights, and edema of her lower extremities. So all those that have to do with weight loss or decrease in swelling, but more specifically, INOs. But Lasix will cause the blood pressure to drop. You know, her skin turgor, if she's dehydrated, daily weights, we're making sure she isn't gaining any and that we're actually taking off what she's already put on, and then her extremities getting smaller or not being as edematous. So what lab test should be ordered? Because the Lasix was ordered.
Potassium.
Fluid and electrolyte.
That's a big gap. That's fluid and electrolytes. So all those electrolytes?
No. Just the potassium because the Lasix.
Okay. So potassium, BUN, and creatinine. Potassium because we know it's a potassium wasting drug, but our BUN and creatinine to make sure our kidneys still work. How do ACE inhibitors help heart failure?
The contractility.
So ACE inhibitors prevent the conversion of angiotensin 1 to angiotensin 2, and it also prevents the release of aldosterone, which actually causes sodium retention and water retention. Right? Remember that? So it reduces the afterload, improves cardiac output, and improves renal blood flow. So they reduce the pulmonary congestion, peripheral edema, and reduce preload by decreasing the aldosterone production. What will determine if the oral dose would be adequate to prepare for discharge?
Because you would go back and you would look at her heart rate, her blood pressure, the edema, and then the weight loss.
Okay, so her INOs,
Yes.
daily weights, and vital signs. So if we're managing to keep that off, then we should be good, right? If our vitals are normal, daily weights are not increasing, there's no swelling, she's putting out pretty well, then we should be A-okay. I believe this is the last question. So, what key management concepts will be important to prevent another relapse?
To educate her and what signs and symptoms to look for, when to call the physician, her blood pressure, her weight gain.
Okay. So she needs to understand the concepts of heart failure and what causes fluid overload, the relationship between diet and medications in her disease process, and she needs to be made aware when she needs to call the physician regarding her BP and weight gain and edema. And that's it. Questions? So any feedback? We've covered three big ones. PVD, hypertension, and now heart failure. I think we covered quite a bit, and we had 2 case studies. So what I would also, because we're going to look at CAD, so I'll probably start with peripheral vascular disease for med-surg, and then we'll go on to the coronary artery disease. I think that's going to be the last of, oh, and then we need to do, we need to also do how to calculate rhythms and all of that. I don't know if we'll do that on Tuesday or not, but we'll definitely pick up with peripheral vascular disease. Ms. Pritchett will more than likely do just pregnancy-induced hypertension, so she'll cover that component. And then we'll do all of the coronary artery disease pieces.
What's a good YouTube video, a good resource maybe for the EKGs? Because I know it's 2 methods, the 1500 divided by
We're going to do the easy one. Count, and it has to be a full complex and multiplied times 10.
Okay, so the wave, I think, what's it, the P to
The R wave, so from R to R.
okay.
But that's a good question. Very good question. But yes, the 1500 gives you a lot more specificity, and you can actually get it down to the actual one. But it's just supposed to be simple. It's not supposed to be, overbearing or anything like that. It's just supposed to be a simple process. So with that being said, then that's what we're going to look at. Okay.
Thank you.
You're welcome.
Thank you.
You guys are welcome. So see you Tuesday.
See ya.
All right.
Bye-bye.
Okay. Bye-bye.
Thank you.
All right. Good night.
Good night.
Night.